Good morning, good afternoon, distinguished leaders, respected elders, our dear colleagues, and members of our Alumni Association. Welcome to today's webinar, which is titled From Guideline to Practice, Key Updates and Insights from the 2025 American Heart Association and the American College of Cardiology Hypertension Guidelines. I thank you all so much for joining us and for your continued commitment to excellence in patient care. My name is Modele Shokumbi of the Distinguished Class of 1982, and I'm the current president of the ICOMAA North America. I'd like to, of course, acknowledge all our important dignitaries. We have the father of the day, Emeritus Professor Oluwole Akonde, the chairman of this webinar, Professor Solomon Kadiri, the president, ICOMAA Worldwide, Emeritus Professor Samuel Omokodian, and of course, immediate past president, Professor Emmanuel Dipo Otolori. I would also like to acknowledge the president of the regional, our sister chapters, Dr. Yomi Shobowale for ICOMAA Canada, Dr. Olu Ajileye for ICOMAA UK, and Professor Akinshola Akimbiyi for New Zealand and Australia. Our Deputy Vice Chancellor Academic, Professor Juwon Arotiba, past Deputy Vice Chancellors who have graciously joined us, and of course, our Chief Host, the Provost of the College of Medicine, Professor Temidayo Ogundiran. We also would like to recognize our past presidents, the very first lady president, or the first woman president of the College of Provost of the College of Medicine, Professor Olayinka Omigbodu. We'd also like to recognize Professor Akinyinka Omigbodu, another past provost, our Chief Medical Director, Professor Jesse Otegbayo, and all our past Chief Medical Directors, our Deputy Provost, Professor S.B. Olaleye, and of course, our own very immediate past Deputy Provost, Professor Fatai Adeniyi. Would like to recognize our present and past Deans of Faculties, distinguished members of the college and University College Hospital Management teams, our distinguished alumni worldwide who continue to do us proud. Now, a special welcome to Professor Famuyiwa, our Board of Trustees, Professor Aoke Johnson, who could not be here but sends his best regards, Professor Kunle Akimboboye, all ICOMAA North America executive members and alumni, our GSAP co-chairs, Dr. Bisi Oshikalu and Professor Bukola Adeshina, and all the executive members. Starting with our father of the day, 1980 to 1984. He was president of the Badok College of Medicine Alumni Worldwide between 2003 and 2007. And in December of 2003, Emeritus Professor Akonde was conferred with the Nigerian National Honors Officer of the Order of the Niger, OON, in recognition of his distinguished contributions to special education and health services, especially the reproductive health in Nigeria and internationally. Our chairman of the day is Professor Solomon Kadiri, a highly revered academic, a great teacher, an astute researcher, and outstanding clinician, trained generations of medical students, resident doctors, and other usage data. He's also the past president of the Nigerian Association of Nephrology, and currently the BOT chair, also past president of Nigerian Hypertension Society, chair of the committees that drafted the Nigerian Hypertension Guidelines for the management of hypertension. Chronic kidney disease management guidelines. She's a past president of the Nigerian Association of Nephrology and a member of the drafting committees for the Guidelines for Nigerian Association of Nephrology. She's presently the Vice President. Number 2, she's the chair of the Webinar Organizing Committee, and she considers it a great privilege to serve the organization. I would also like to recognize, of course, the co-chairs of the Student Hostel Project, our very own Professor Major General Shina Ogunniyi, MNI, and Professor Gbemisola Oke. Now, to get to the middle of things today, that's why we're here. Hypertension remains the leading driver of cardiovascular morbidity and mortality worldwide. The 2025 American Heart Association and the American College of Cardiology has introduced important updates at closing the gap between evidence-based recommendations and, of course, real-world clinical practice. Today's session, of course, is going to be amazing. It would highlight key guideline updates, provide clinical insights, support transition of guidelines into daily practice. Now, before we get started, please, just a few quick housekeeping notes. Stay muted unless you're speaking. Use the chat box to share comments and questions. We'll have a dedicated and robust Q&A segment after the presentation. Please take a minute just to help us out. Rename yourselves and add your email, because after this webinar, you will have access to the YouTube recording, of course. We'll also share documents in PDF format for the 2025 AHA and ACC hypertension guidelines. Now, without further ado, it is my great pleasure to introduce to you Professor Modele Ogunniyi. She's a highly respected academic clinician, a leader with extensive expertise in cardiovascular medicine and hypertension management. She's widely recognized for her contributions to clinical excellence, research, and medical education. Permit me, I have 2 pages to read, but it's very important. We're really honored here to benefit from her insights as she guides us through the key updates of the 2025 hypertension guidelines. Dr. Modele Ogunniyi is a professor of medicine and a master physician in Emory University Division of Cardiology. She also serves as the director of the Georgia CTSA, the Clinical Research Center at Grady Memorial Hospital, and also as associate medical director of the Grady Heart Failure Program. She earned her medical degree, of course, from the prestigious University of Ibadan, the College of Medicine. She holds a master in public health and a certificate in health finance and management from Johns Hopkins University. Her postgraduate training includes preventive medicine fellowship at the Centers for Disease Control and Prevention and internal medicine residency at Morehouse School of Medicine, and a cardiology fellowship at Vanderbilt University, where she was the very first Black female cardiology fellow. Dr. Ogunniyi is a nationally recognized investigator and researcher whose work focuses on improving cardiovascular outcomes through an equity-centered lens. Her research addresses social determinants of health and persistent cardiovascular disparities, with particular emphasis on hypertension, heart failure, cardiovascular disease in women, and more importantly, inclusion of underrepresented population in clinical research. She has extensive experience designing and leading pragmatic, community-engaged, and health system-based research with a strong record of integrating implementation science, population health, and policy-relevant questions into cardiovascular clinical research. She's widely recognized for her leadership in improving clinical trial representativeness and developing strategies to promote equitable trial participation. Through her extensive work with national research networks and as director of the Georgia Clinical Research at Grady, she provides strategic leadership for clinical and translational research infrastructure, mentors investigators, and advances equitable access to research participation. Professor Ogunniyi is the co-author and author of numerous peer-reviewed publications, reviews, scientific statements in leading cardiovascular and medical journals. She frequently contributes to national guidelines, documents, and educational curricula, and also serves on the editorial board of Clinical Cardiology. Her scholarship closely aligns with her national service and guideline development work, including, of course, a service on the 2025 the American Heart Association and the American Cardiology College of Cardiology Hypertension Guideline Writing Committee. Her passion for mentorship, for creating equitable pathways to diversify medical workforce is evident in all aspects of her work. She has received multiple institutional and national awards recognizing excellence in mentorship, teaching, diversity, and inclusion. In recognition of her efforts, she received the Emory School of Medicine Excellence in Diversity and Inclusion Award, along with several mentoring and teaching awards, including the R. Wayne Alexander Research Mentoring Award, the Emory at Grady Excellence in Teaching Award, the Impact Outstanding Attending Mentor, the Outstanding Research Mentor Award from the Emory Internal Medicine Residency Program. Her commitment to mentorship, a crucial aspect of her professional journey, is deeply felt by her mentees and stands as a testament to her dedication to the next generation of medical professionals. Professor Ogunniyi's service extends beyond her research and mentorship. She's actively involved in volunteer work. She belongs to a lot of professional organizations, including, of course, the prestigious American College of Cardiology, the American Heart Association, the Association of Black Cardiologists, where she currently serves on the board of directors, underscoring her commitment to the medical community. In addition to all this involvement, Professor Ogunniyi has had leadership positions on national committees, co-chair of the ABC Membership Committee, chair of the AHA Q's Core Scientific and Clinical Education Lifelong Learning Committee. She serves on the board of directors of the Heart Disease and Stroke Prevention. She's a member of the ACC's Cardiovascular Disease in Women and Diversity, also the Inclusion Committee and the AHA Women's Health Science in Cardiology Committee. Her unwavering commitment to global health is not merely a part of her work, but a testament to her dedication to health equity. As Vice President of the Health Awareness Initiative Africa, a nonprofit organization, she leads efforts to promote healthy lifestyles in African communities through screening and education. Ladies and gentlemen, please give a warm welcome to our distinguished speaker, Professor Modele Ogunniyi. It is with great pleasure that I present you Professor Modele Ogunniyi and her presentation. Thank you very much.
Thank you, Dr. Shokunbi, for that warm introduction. I was wondering who you were talking about, but thank you for that warm introduction. Good afternoon, everybody, all our elders. I will do full acknowledgements at the end, but in the interest of time, I wanted to go ahead and get started. And permit me for now to stand on existing protocols, but I acknowledge and I honor everyone here today. So over the next 45 minutes, I'll be sharing with you key updates from the newly released hypertension guidelines. So our learning objectives, I'll summarize key updates and the recommendations, describe evidence-based strategies and the implications for guiding hypertension management across diverse patient populations. We'll also look at special considerations for older adults and pregnant women. And when you have all these guidelines, you want to make sure that you're able to translate it into clinical practices. So we'll look at some practical approaches. And also, I will discuss at the end a few slides looking at the 2023 Nigerian Hypertension Guidelines, of which we have a number of the authors on this call as well. So why hypertension, has Dr. Shokunbi eloquently said in her introductory remarks? It is the leading cause of cardiovascular morbidity and mortality globally. Globally, over 1.3 billion adults have hypertension. And when you look at the continent of Africa, almost half of Africans have hypertension. Bringing it back home to Nigeria, 1 in 3 adults have high blood pressure. And here in the US, we define high blood pressure as a systolic blood pressure greater or equal to 130 and or diastolic blood pressure greater or equal to 80. And when you look at the whole population, almost 50%, a whopping 122.4 million people have high blood pressure. And when you look at the racial and ethnic disposition, Black people really suffer a huge burden of hypertension. In fact, when you look at the global prevalence of hypertension, Black people have the highest prevalence. And despite the fact that we have all this data, hypertension control remains a persistent public health crisis. When you review the data, be it here in the US, in Africa, or globally, the control rates for hypertension remain abysmal, especially for racial and ethnic populations. So why focus on blood pressure? It is the most prevalent and modifiable risk factor for the development of cardiovascular disease. And when we talk about cardiovascular disease, we're talking about the whole spectrum: coronary artery disease, heart failure, atrial fibrillation, stroke, dementia, chronic kidney disease, and even all-cause mortality, leading cause of death. And when you look at the spectrum of cardiovascular kidney metabolic disease, which is a new spectrum that we are defining now to kind of look at the interplay between the heart, the kidney, and the metabolic system, high blood pressure remains as an underlying and significant contributor. The overarching treatment goal, less than 130/80 for all adults, is a point that I would like you to take home today. Of course, when we think about older adults, people who are institutionalized, people who have a limited lifespan, who are pregnant, which I'll share later, the treatment goal is different. So this is just the US, where we define high blood pressure control as a systolic less than 130 and a diastolic less than 80. Only about 1 in 5 adults have their blood pressure control. And as you can see from this slide, over the years, we're not doing a good job. The rate of control of hypertension is still abysmal. Let's bring it back home to sub-Saharan Africa. Recently published by Gafani, Matamene, and colleagues, they looked at the prevalence. Notice this is one difference I'll highlight here. In sub-Saharan Africa, and I will crave the indulgence of the participants not to annotate on the screen, Nini. And if the IT people could disable the annotation by Nini on my screen. Thank you. So moving on, hypertension prevalence in sub-Saharan Africa. And like I mentioned, in Africa, blood pressure control is defined or hypertension is defined as a systolic blood pressure of greater or equal to 140 or diastolic blood pressure greater or equal to 90. As you can see, the dark colors mean a high prevalence of hypertension. So in Nigeria, greater than 35% prevalence means those who have an existing condition. So you can see the whole of Nigeria is dark red. We have a lot of work to do. And when you look at this, this is the most recent data that I could find, written by Oji and Auger, Professor Auger and colleagues, looking at the prevalence in Nigeria. And that's where I got the data that 1 in 3 adults, 30%, is the prevalence of hypertension. I'm gonna look and see if I can get rid of this annotation. Hold on a second. I'm not sure how to do that. Anyway, IT, if you could get rid of the annotation, I'll appreciate it. So moving on, it's all over my slides. Let's see if we can get rid of it. No, I think I'm erasing it. Cool. Okay, good. Thank you. So let's move on and talk about the 2025 guidelines. One thing about the guidelines is that it was a joint effort, a multi-society. So as you can see, it was not only the American Heart Association, but we had nurse practitioners, physician associates, geriatrics, cardiologists, preventive medicine, nurses, and primary care providers. So this, just to acknowledge my writing committee members, lots of effort and work and time went into this. And I will pause here and say, as I go through the presentation, one thing I want you to note is that green means good. It means that the recommendation is highly beneficial, as you can see. Class 1 is a strong, the highest strength of recommendation where the benefits far outweigh the risk. Class 2A you have moderate strength of recommendation. The benefits outweigh the risk, but not has a level of evidence of 1. Class 2B, weak, and red is strong. So red means no. This should not be done. And with each class of recommendation, we also assign a level of evidence. So level A means our guidelines were derived based on the highest level of evidence, which is usually randomized control trials or meta-analysis of high quality randomized control trials. Level B means moderate quality, randomized trials too. Level B, non-randomized trials. And as you can see, some of the other level evidence C, you can have limited data or just expert opinion. This becomes very important as I go through the guidelines. So how do we define hypertension? So in the new guidelines, in the 2025 guidelines, the definition did not change. One difference between our guidelines and the Nigerian guidelines is that this guidelines is focused on adults, whereas in the Nigerian 2023 guidelines, they include the pediatric population. So kudos to the team. So we categorize high blood pressure as normal, elevated, stage 1 or 2 hypertension. And this is what we mean. Categories of blood pressure. So normal blood pressure is a systolic blood pressure less than 120 and diastolic blood pressure less than 80. A patient is classified as having elevated blood pressure if they have a systolic blood pressure within the range of 120 to 129 and a diastolic blood pressure less than 80. I want you to pay attention to the and the ors. Now, stage 1 hypertension is 130, systolic of 130 to 139, or a diastolic of 80 to 89. So if you have a patient who has a blood pressure of systolic blood pressure of 130, but their diastolic is 89, or their systolic is 120 and the diastolic is 89, according to these guidelines, they have stage 1 hypertension. In contrast to the definition of hypertension in the 2023 Nigerian hypertension guidelines, hypertension, they have a higher threshold. And stage 2 hypertension is systolic blood pressure greater or equal to 140, or a diastolic blood pressure greater or equal to 90. So what's new in these guidelines? These guidelines, the last guidelines were in 2017. So I'll just go through a few things. I think for me, as a member of the writing committee and as a clinician who sees patients, this recommendation is really one of the most important things in my own opinion. As a clinician who sees patients are really scared of developing dementia or even mild cognitive impairment, which is the precursor. And based on the evidence that we have, we know that intensive lowering of blood pressure reduces the risk of mild and cognitive impairment and dementia by 15%. That is really significant. Hay and all in a publication in Nature accumulated the evidence and showed that lowering blood pressure reduces the risk not only of dementia, but of mild cognitive impairment. Another emphasis that we really spent a lot of time talking about, that I think it's applicable not only to us as clinicians, but to our patients, is that we had a lot of focus on lifestyle and psychosocial approaches. By psychosocial, we mean the effect of stress on high blood pressure. Notice that in the old guidelines, that was not called out. But in the 2024 guidelines, one of the things we call out is potassium-based salt substitutes. And that's really important because we know that Black people have salt-sensitive high blood pressure. And based on the available evidence, we have come up with a 2A recommendation that potassium-based salt substitutes can be useful to prevent or treat elevated blood pressure, especially in patients whose salt intake is high. When you think about, how our diet, you think about adding the Maggi and the Knorr and the salt. One thing you can do or share with your patients is that instead of the salt, to use potassium-based salt substitutes. And here in the US, we have things we call Mrs. Dash. But it's good to know how to read labels and make sure your salt substitutes are high in potassium. But there's a caveat to this. Patients who have chronic kidney disease, who have difficulty in excreting potassium, we will not want them to use potassium-based salt substitutes, as well as patients who are on drugs that reduce potassium excretion. In such patients, monitoring is required. This is one of the recommendations that I'm really proud of. For the first time, we address hypertension and pregnancy. We usually refer to pregnancy as a stress test. And I know if I take a poll on this webinar of our women, a lot of people will say, when I had my baby, I was diagnosed with hypertension, or I had preeclampsia, or I had chronic hypertension. So for the first time, we call out hypertension in pregnancy because of the excess cardiovascular morbidity and mortality. But like I mentioned earlier, the threshold for hypertension in pregnancy is different. So our recommendation is that pregnant individuals with systolic blood pressure greater or equal to 160 or a diastolic blood pressure greater or equal to 110, confirmed on repeat measurements, should receive antihypertensive medications to reduce their blood pressure. Notice the threshold, less than 160 over less than 110. The individuals coming into pregnancy who already have chronic hypertension, and that we define as a systolic blood pressure between 140 and 159, and a diastolic blood pressure between 90 and 109 prior to 20 weeks of gestation. That is, they have chronic hypertension. In them, we want to be more aggressive, but their goal blood pressure is 140 over 90. And for the first time, we recommend a low dose aspirin. So that's one teaching point. If you're taking care of someone who has chronic hypertension and is planning a pregnancy or is pregnant that you're seeing them, you should put them on low dose aspirin, by that 81 milligrams. Randomized trials have shown that it decreased the risk of preeclampsia and its sequelae, both for the mother and the baby. So I want this to be interactive. So I have a couple of clinical cases so that you all don't fall asleep on me. So this is our first clinical case, and I'm going to launch a poll. I hope you're paying attention. This is a patient I saw in clinic, a 35-year-old Black man who just got a job and was referred to me for a pre-employment physical exam. He tells me he doesn't have hypertension, he doesn't have any cardiac symptoms, he's not short of breath, doesn't have chest pain. He actually doesn't take any medications. He doesn't smoke. He's a social drinker with alcohol. And on examining him, his exam was unremarkable. His BMI was in the healthy range. And taking his blood pressure, and we'll talk about this, we really emphasize the proper technique and taking average blood pressure. So you can see that his blood pressure was 136 over 88, an average of 3 readings. I'm introducing to you this term, the PREVENT calculator. So when we calculated his PREVENT risk of developing, 10-year risk of developing cardiovascular disease, it was low, about 1.3%. You can see that his routine lab studies, their routine tests that need to be done for a new diagnosis of hypertension, everything came back normal, and he didn't have any history of diabetes or chronic disease. So this is the PREVENT calculator. I have added a QR code. If you scan the code, it will go, you can go to the link. But the PREVENT calculator is a new calculator developed by the American Heart Association to really assess cardiovascular kidney metabolic risk, because we know that hypertension is a major risk factor. And as you can see, this calculator is online. A patient comes in and you put in the numbers. You can calculate their risk of total cardiovascular disease, atherosclerotic cardiovascular disease, and heart failure. So I plugged in the number for my patients. The other thing about this equation is that you can also add extra predictors. You can add the urine albumin creatinine ratio, hemoglobin A1C, and the zip code, which is kind of a marker of social determinants of health. So for my patient, the estimated 10-year risk of developing cardiovascular disease is 1.3, very low, and a 30-year risk of 9.7. This becomes important in determining when to treat the patient. So this is the first question. We're going to launch the poll. My question to you is that what will be the evidence, and I'm showing the answer. What will be the evidence-based recommendation for blood pressure of 136 over 88? A, he has stage 1 hypertension and needs medications immediately. B, for effective lifestyle modification, he should limit his sodium. However, he can continue to drink. C, wait until 3 to 6 months of lifestyle modification. If his blood pressure remains elevated, start antihypertensive medications. D, since his prevent risk is less than 7.5, he does not need any drug. So I will launch the poll for a few seconds, and I encourage you to vote. And the poll is live, if you can see it. I think we have over 90 people. So far, we have 20 people voting. Once we have 50 people, I'll end the poll in the interest of time. Okay, I am going to end the poll. 55 people voted, and I hope you can see the results. 53% were correct. Wait until after 3 to 6 months of lifestyle modification. If his blood pressure remains high, start antihypertensive pregnancies. Antihypertensive medication, sorry. Okay, let's go into the discussion. And that is the answer. So I will go into that discussion. We're going to wait 3 to 6 months. And then if his blood pressure is elevated, we're going to start treating him. So he comes back to you in clinic after 6 months of lifestyle modification. He's significantly reduced his alcohol intake in addition to the recommended lifestyle changes. He measures his blood pressure at home with a validated blood pressure monitor, and his blood pressure is between 135 to 140 over 80 to 85. His blood pressure in the office today is 132 over 82. And he says, "Doc, if you think I need blood pressure medications, I'll take it." What do? Do you start medications? Do you say, "Wow, your blood pressure is good, see me in 3 months"? Do you use metoprolol, tartrate, or combination therapy, or start amlodipine, or all of the above medications appropriate as initial therapy? So let's see if, let's see if I can get to share. I have to share the poll and I can't get to the share. But anyway, let's move on. So the answer is amlodipine 5 milligrams once daily. And I know people are thinking, really? But this is someone who has newly diagnosed high blood pressure. He doesn't have any comorbidities. So a single dose medication, a single pill, it will be okay for him. So we're going to talk more about why that is so. So big picture, I talked about the blood pressure categories for diagnosis. We talked about all the categories. That's kind of how are you aware that you have blood pressure. But there's also the threshold at which you start treatment. And not only do you want to start treatment, you want to get to control. And what do we mean by control? So this is how we write in the guidelines how to decide whether a patient needs to be treated. So you look at the blood pressure. If the average blood pressure is greater or equal to 140 over 90, the guidelines say strongest level of evidence, start blood pressure medications. Why? One, it's essential to lower the blood pressure and reduce the risk of developing cardiovascular disease, and even in those who have cardiovascular disease, for secondary prevention. So for example, in our patient, his blood pressure was not greater than 140 over 90. The next question to ask is that, does this patient have existing clinical cardiovascular disease? Do they have coronary heart disease? Do they have stroke or heart failure? Case 1, the patient had neither. So you're going down this trajectory. Then you ask, does the patient have diabetes or chronic kidney disease? Or do they have an elevated 10-year prevent CVD risk? Remember, our patient had a risk of 1.3. So the answer is no. So in that patient, you will not start antihypertensive therapy until 3 to 6 months of lifestyle intervention. Going to the other side, if a patient has an average blood pressure greater than 140/90, you start treatment. If a patient, though does not have has a blood pressure of like in the 130s, if they have existing cardiovascular disease, you start blood pressure medication to reduce their CVD risk. If a patient has a blood pressure greater over 140/90, they don't have clinical CVD, but they have diabetes, they have chronic kidney disease, or an elevated prevent risk score, you start blood pressure medications. So it's a risk-based algorithm to determine who do you treat. Blood pressure less than 140/90, no diabetes, no CKD, no CVD. It is recommended that they try lifestyle modifications for 3 to 6 months before you treat them. But if they have any of this, irrespective of what their blood pressure is, you should initiate therapy. And that's putting it together. Lifestyle modifications before medications with patients with low prevent risk and an average blood pressure in the 130s, diastolic in the 80s. Give them an opportunity for 3 to 6 months of lifestyle intervention, then initiate medication. This is new in these guidelines. So putting it all together again, we've talked about how to make the diagnosis, the threshold at which to initiate treatment. Now, what is the blood pressure goal? Adults with hypertension, you look at their prevent risk. The goal for people with elevated risk is a systolic blood pressure of less than 130. Ideally, we want to get people to a systolic blood pressure of less than 120 because the evidence shows that the lower the blood pressure, you are reducing the risk for cardiovascular disease. And notice this is in green, the highest level of evidence, a class 1 evidence, and you want the diastolic blood pressure to be less than 80. If they have a lower ASCVD risk, we notice that they still have the same goal, howbeit a lower class of evidence, class 2B. So your take-home point is that the lower the better. We want to get people to a blood pressure of less than 130/80, especially if you have a high risk. And for everybody, really, ideally, we want your blood pressure to be less than 120/80. So in summary, keys of decision-making as you see your patients, as you think about high blood pressure. In these new guidelines, there's no change to blood pressure categories. When you think about the blood pressure threshold, always think about the risk. Risk less than 7.5%, stage 1 hypertension, lifestyle modification for 3 to 6 months. But if not, treat. And the goal blood pressure, systolic blood pressure, is less than 130, ideally a systolic of less than 120. I hope you're still awake. Let's go to a second case. 55-year-old woman referred for difficult to control hypertension. She was diagnosed with hypertension during her first pregnancy. She has no symptoms. She has obstructive sleep apnea and has been given a CPAP machine, continuous positive airway pressure machine, to treat her sleep apnea, but she hardly uses it. She has chronic atrial fibrillation and she's obese. She tells me that both her parents and her 2 siblings have hypertension and diabetes. She doesn't smoke. or use tobacco. She drinks alcohol occasionally. Look at her drug regimen. She's on lots of medication, combination therapy. 4 medications, valsartan, amlodipine, HTZ, which is X4 HTZ, 3 medications at the highest dose. And in addition to that, she's on a beta blocker, 25 milligrams carvedilol. On exam, because she's atrial fibrillation, her heart rate is irregular, she has S4. S4 is evidence of a stiff heart, LVH. That tells me she's had long-standing hypertension. And she has a mitral regurgitation murmur at the left lower sternal border. And her BMI shows that she's obese. The average reading of her blood pressure is 136/88. So what is the next course of action for managing her blood pressure? And I think I can launch the poll now. So will you start spironolactone? Will you check plasma renin aldosterone? Hold her blood pressure, check aldosterone medication, hydralazine, diazem for 1 month, and then check plasma renal aldosterone. So if you can vote on this. She has difficult to control blood pressure. End this in the interest of time and share results. So about half say check plasma renin aldosterone, which is the correct answer. But I'm a bit worried about those who chose D, who says substitute a blood pressure medication. And if you can put in the chat why that was your choice, I am really interested in knowing. A few said start spironolactone, but the correct answer is check renin aldosterone, plasma renin aldosterone. And we'll go into that. We all know about secondary hypertension. And in this patient, we see that the patient is on about 4 medications, resistant hypertension. So for the first time in these guidelines, we actually say we need to screen for primary aldosteronism, regardless of hypokalemia. I know when I was in medical school and in training, we looked at people who had hypertension and hypokalemia and said, oh, well, their potassium is normal. They can't have primary aldosteronism, but evidence shows otherwise. So if you have a patient difficult to control hypertension, regardless of the potassium status, it is recommended that you screen for primary aldosteronism. And in adults in which there's an indication, you do not need to stop their medications. The only medications which you should not start or continue is a mineralocorticoid receptor antagonist like spironolactone and epinephrine. And that's why D is incorrect. You can continue their medications, but you wouldn't start spironolactone in this person because you want to screen for hyperaldosteronism. So resistant hypertension, you really, when you see a patient whose blood pressure is not controlled despite being on 3 or 4 medications, it's important to evaluate for secondary causes. Notice in the patient I presented, the patient had obstructive sleep apnea, was not using their CPAP. That can drive up blood pressure. Look at their medications, make sure they're taking the correct doses. There's some things like NSAIDs, like Tylenol, like paracetamol, like Motrin, things that raise blood pressure. So it's important to do a deep dive and a careful evaluation of medication and secondary causes when you see a patient who has difficult to control blood pressure. There is a new therapy. We will not talk more about this, renal denervation, but just to say that a multidisciplinary team and people who have expertise in resistant hypertension is needed. And it takes a lot of looking at the risk versus the benefit, and having an informed discussion with the patient. Also, in patients with uncontrolled hypertension, it's important to use team-based care, to find out why their blood pressure, could it be stress, do they have things that they're dealing with, the psychosocial aspect that I talked about, nutritionists. It's all about working together as a team. And also using home blood pressure monitoring. We all know that patients, when they come into the clinic, they can't find parking, they get into the waiting room before they can even sit down, the MA comes in, takes their blood pressure, the blood pressure is 150/90. Evidence has shown that home measurements of blood pressure can be reliable. So what I usually do is make sure my patients have validated blood pressure monitors and record their blood pressures at home in normal environments. And that can help you see what their blood pressure. It also helps you to rule out what we call white coat hypertension. People who come into the office, their blood pressure is high, but at home, they bring you readings. So the importance of measuring your blood pressure at home with the right kind of validated blood pressure monitoring is important. In this day and time when we have health information technology, the readings feeding into the electronic records is very important. And telehealth, having people call the patients, monitor the blood pressure. And it's important I think that another cause of uncontrolled hypertension is actually clinician inertia. I can tell you how many times with my residents and fellows where they're always trying to give me a reason why the blood pressure is high. They're like, oh, he forgot his key at home. He couldn't find parking. He had an argument with his spouse before he came, But it's important that when you see uncontrolled hypertension, because of the morbidity and mortality, that you intensify medical therapy and have regular follow-up. It doesn't have to be in person. It could be with telehealth. So back to our case, we're almost rounding up on the cases. This is an elderly lady who was sent to me, no cardiovascular disease, but she has diabetes, which is really well controlled. Hemoglobin A1C of 6.4, she's on metformin. She used to smoke, she's cut down, half pack per day. She's very active, walks in a neighborhood, and you can see her blood pressure 130 to 135/80 to 85 on her most 3 recent office visits. She also tells me that her home blood pressure is in the same range. Her BMI is unremarkable, is within normal range. And in the office, the average of her blood pressure is 136/86. Her potassium is normal, 3.7. Normal is about 3.5 to 4. She has stage 3 kidney disease. Her GFR is 53. It should be above 60. And her urine albumin creatinine ratio is 90. It should be less than 30. So this person has diabetes and also has chronic kidney disease. So my question to you is that what is the most appropriate next step to manage this patient? Would you say your blood pressure in the 130s/80s, continue current management? Will you add lisinopril? Will you add semaglutide? Will you add finerenone? Or will you add empagliflozin? Let's see if we can launch the poll. Relaunch poll. Okay, hope you can see it. So what would you do? And if you can type in the chat why you picked that option, that will be good. Okay, I will end the poll here in the interest of time and share results. So about a third say continue to monitor blood pressure, lifestyle modifications, follow up in 3 months. The correct answer is B. 40% said add lisinopril. 20% said add empagliflozin. So if you picked option A, if you could put in the chat, I'll review it later, why you picked option A. So the answer is lisinopril. And this is because this patient has diabetic kidney disease, they already have evidence of microalbuminuria, and we know that like the addition of a ACE inhibitor or an ARB will slow that progression. And this is the recommendation. In adults with diabetes and hypertension, ACE inhibitors or ARBs are recommended in the presence of chronic kidney disease, which a patient already had, and should be considered even when mild albuminuria is present. The goal is to reduce the progression of diabetic kidney disease. And even in the absence of diabetes, if a patient has hypertension and chronic kidney disease, GFR less than 60 with albuminuria, ARB, or an ACE inhibitor, not both, is recommended to decrease the progression. Coming on, our second to last case, a 45-year-old female with hypertension and migraine headaches comes in for an office visit. She feels well. She has no symptoms at all, no migraines. She's on a combination therapy of losartan, HCTZ. She hasn't taken her medications in the last 2 days. And the average, notice I keep on talking about average of blood pressure readings. We don't take management decisions based on one reading. Was 185/110. On exam, she has an S4, which tells me she's had long-standing hypertension and a stiff heart with LVH. Otherwise, her exam is unremarkable. Her ECG also shows evidence of hypertensive heart disease. She has left ventricular hypertrophy with secondary repolarization changes. So what will you do? Her blood pressure is 185/110. Will you send her to the emergency room for IV blood pressure medications to lower her blood pressure? Would you give her home med? She hasn't taken it in 2 days. And say, hey, ma'am, sit there for 3 hours. Let's monitor your blood pressure. Will you give her clonidine to reduce her blood pressure and remeasure her blood pressure in 1 hour? Would you ask her to take her medications and return to clinic in 2 weeks? So if we could quickly vote on this and we'll move on. What would you do? Blood pressure is 185/110, no symptoms. She forgot to take her medications. What will you do? Okay, I will end the poll and share the results. And I am so disappointed. We don't have the luxury of time. Administer losartan. Most people said administer losartan and observe in the clinic for 3 hours. That ain't possible. And remember that losartan HCTZ is a chronic medication. The answer is actually D. Just tell the patient, start taking your medications when you get home and follow up with me in 2 weeks. Remember that this is chronic hypertension and the patient has no symptoms. So let's talk more about that. That is the answer. So in defining this patient, her blood pressure was 185/110. She had no symptoms. So she will be someone we define as having severe hypertension. I know that when we were in training, we used to use the term hypertensive urgency, meaning elevated blood pressure without any symptoms. That has been taken out of the guidelines. We now call it severe hypertension. So blood pressure greater or equal to 180/120 with no target organ damage. And hypertensive emergency is a blood pressure of greater or equal to 180/120 with target organ damage. Could be stroke, could be MI, could be headaches, could be papilledema, whatever that is. You know, I still remember being in Professor Akikugbe's nephrology and hypertension unit, and how we used to look in the eyes for evidence of hypertensive retinopathy. So this person has severe hypertension, no evidence of target organ damage. And it's a class 1 recommendation that you should treat them in the outpatient setting. So that patient went home to take their medication and will come back in 2 weeks. There is no need to emergently reduce the blood pressure. There's no need to have the patient wait and take the blood pressure. The blood pressure is not going to go down. So that is the answer to that. Remember, it's severe hypertension. There was no evidence of organ damage. Just to quickly talk about stroke. Now, in the inpatient setting, if you have a patient with a stroke, acute spontaneous intracranial hemorrhage with a high blood pressure between 150 and 120, it is beneficial, notice, to reduce immediately the blood pressure to 130 to less than 140 for at least 7 days. Why? Because it improves functional outcomes and it helps the patient. Now, if the blood pressure precipitously drops to less than 130, you can stop antihypertensive medication. This is in the acute setting. If a patient has acute spontaneous intracranial hemorrhage and you're reducing the blood pressure, you got to be careful because you don't want to drop the blood pressure in that acute phase so low, but you still want to control the blood pressure. And in red, that is a no-no. I showed you at the beginning. Now we have a lot of evidence-based treatments for patients who have ischemic strokes, and within the first 24 to 72 hours, we do what we call permissive hypertension. You do not want to lower their blood pressure that low because it can worsen functional outcomes. And this is my last case. I hope everybody is still awake. 75-year-old male with hypertension and type 2 diabetes, as you can see, very well controlled, hemoglobin A1C of 5.4. He's asymptomatic. He's not dizzy. He doesn't feel weak, no lightheadedness at rest or with exertion. He's active for his age. He walks 1 to 2 miles, 3 to 5 times a week in the neighborhood with no symptoms. His medications, metformin for diabetes, atorvastatin for hyperlipidemia, and his blood pressure medications are hydrochlorothiazide at max dose and amlodipine. So you take his vital signs. Lying down, heart rate is 70. Blood pressure is 150/86. And then as he stands, his blood pressure drops to 116/75. He doesn't feel dizzy. He doesn't feel lightheaded. What will you do? Let's launch the poll here. Let's see. Add losartan 25 milligrams to reduce the risk of orthostatic hypotension. Reduce the risk dose of HCTZ to avoid orthostatic hypotension. In older adults, intensive blood pressure lowering may be associated with a higher risk of falls and fall-related injury. And D, lowering systolic blood pressure to less than 130 confers more risk than benefit in this older adult. Let's see what people think. In interest of time, I will end the poll. And to share the results, only 2% were right. Okay, so this webinar was much needed. The correct answer is A, add losartan, and I'll explain. I can see why most people picked option C. We'll talk about that. And thank you for being an interactive audience. This is helpful. So this is the answer, add losartan. If you go back, you will see that, let's go back to the case. Lying down, the blood pressure was 150/86. So this person has what we call orthostatic hypertension. The blood pressure is still not controlled. So we examined a lot of evidence, including the SPRINT trial, which is the most common trial, where they were intensive blood pressure lowering. The goal there was even 120. And examining all those trials, actually in adults with hypertension, controlling their blood pressure reduces the risk for orthostatic hypertension. Notice it's in green, the highest level of evidence. And level of evidence is A, strength of recommendation is 1. So that means that we examined high quality evidence and randomized clinical trials. It sounds counterintuitive to say, oh, well, his blood pressure dropped, but notice he was asymptomatic and his blood pressure was 150/86 normally. A class 2A evidence is that it is in patients receiving blood pressure medications who are asymptomatic. That's the key. You want to treat their blood pressure to less than 130. It's reasonable because we know that when you lower blood pressure, you decrease the risk of cardiovascular disease and the risk of death. And when you have someone who has high blood pressure, you should look at reasons for orthostatic hypotension. So patients who have Parkinson's, patients who are on multiple medications, elderly patients, institutionalized patients, patients who are at risk for developing hypotension. There's a caveat there to assess for symptomatic orthostatic hypertension. Because when you treat, it is going to unmask symptomatic orthostatic hypertension. But notice that our patient was asymptomatic and did not have any of the predisposing factors for orthostatic hypertension. So I'll be running up and just share with you briefly the 10 take-home messages, and I hope that we can have a robust discussion. We talked about this already. Hypertension is the most prevalent modifiable risk. And I talked about dementia and mild cognitive impairment. Controlling blood pressure reduces the risk by 15%. Goal blood pressure less than 130/80. Importance is the role of this is a public health problem. So it's not just the clinician collaborating with the government, with health systems to screen adults and implement guideline-directed therapy. I also talked about the team-based care. It's important that clinicians partner with nutritionists, exercise physiologists, nurses, dietitians to get blood pressure to goal. And not only that, using home blood pressure monitoring and making sure that we address adverse determinants of health. So it requires an integrated plan model and reviewing blood pressure. Multidisciplinary team-based care, and you can see the team members here, community health workers, dietitians, physician assistants. We've talked about the blood pressure categories as well, how you define high blood pressure. Diagnosing blood pressure in the office. When your staff are measuring blood pressure, that's not the time to be saying, oh, how was your Thanksgiving? How was your holiday? You shouldn't be talking to the patient. It's important to use the correct size of cuff, because if you don't use the correct cuff size, the blood pressure might be elevated or low. And if you go to this website, there are validated blood pressure monitors that are recommended. Of course, for the patient, you don't want to slap that blood pressure cuff as the patient walks in. You want to make sure the patient has emptied their bladder. They should relax. Their feet planted on the floor for more than 5 minutes. That may be hard to do in a busy office. And you shouldn't be talking. That's not the time to catch up on gist with your patient. And the patient should not be texting on their phone or be on a WhatsApp. It's important to be still to get accurate blood pressure. Believe me, all these little things affect blood pressure. I've talked to you about lifestyle changes, maintaining a healthy weight, low salt diet like the DASH diet, increasing potassium intake, physical activity. In all my cases, you notice that I mentioned physical activity. And in this, we actually say reduce or eliminate alcohol, and that may be a bit controversial, but really alcohol cessation decreases blood pressure. This is how to measure blood pressure: the arm at the heart level, feet planted to the ground using the appropriate side of cuff, not talking to the patient. You can get all this, in our waiting room, we have this pasted there so that the staff can know this is how patients need to be seated and this is what to do for measuring blood pressure. We talked about lifestyle changes. Losing at least 5% of body weight achieves significant blood pressure control. The DASH eating plan, low salt diet, reducing your sodium intake to less than 2,300 milligrams per day, ideally 1,500. adults with hypertension or without hypertension. You know, we had a lot of discussions. Should we say alcohol abstinence? But we said we may not be in the majority, but so we said reduce. But abstinence really is the main goal. Structured physical activity, resistance training, aerobic exercise, all these are things that we can do as clinicians, not only recommend to our patients, that will decrease our risk of cardiovascular disease and control blood pressure. We've talked about initiating blood pressure therapy, the goal blood pressure, the prevent risk, less than 7.5, blood pressure in the 130s, okay to do lifestyle. Greater than that, with cardiovascular disease or diabetes, start medications. Stage 2 hypertension, this is something I hadn't mentioned. We recommend that you use a single dose, fixed dose combination. So for example, losartan, HCTZ, lisinopril, HCTZ, amlodipine, you know, a combination. Why? Because it's easy to take a pill that has 2 medications than to take 2 separate pills. So it promotes adherence and facilitates blood pressure control. Home blood pressure, that's one thing I want you to take away, measuring your blood pressure at home. But not only measuring blood pressure, but communicating with your care provider. It doesn't have to be the physician or the nurse practitioner or the physician associate. There are people, the nurses, using standardized protocols that can help take actionable steps to get us to goal. There are lots of things, especially on Amazon, cuffless devices, smartwatches. I get that question all the time. Can I use that to measure my blood pressure? Well, we don't have the evidence. Maybe in the next reiteration of the guidelines, but you can see that it is red. Do not be using smartwatches or cuffless devices to monitor your blood pressure because we don't have the precision and reliability now. As important as it is for you to measure blood pressure in the clinic, you also have to educate your patients. Same thing at home. Make sure your arm is at the level of your heart, your feet planted on the ground. Empty your bladder. Avoid smoking, avoid coffee, avoid Coca-Cola, avoid exercise within 30 minutes of measuring your blood pressure. Measuring on a bare arm. I know how many times you've been to, and you see the staff slapping the cuff on a shirt. You know, it should be on the bare arm, relaxing, not watching TV, not talking, the same way. Very important. You'll be amazed how this can get us to accurate blood pressure readings. I already talked about severe hypertension. Severe hypertension, elevated blood pressure, greater than 180 over 120, no acute target organ damage. No need to admit, no need to send to the ER. Treat in the outpatient setting with plans to follow up as soon as 2 weeks. Intensify blood pressure medication. And lastly, I wouldn't do justice without giving credit and really reviewing the 2023 Nigerian Hypertension Guidelines. A lot of my professors and teachers on this call were co-authors and helped to develop these guidelines. And kudos, one of my classmates, Dr. Emmanuel Agogo, actually engaged me at the time they were developing these guidelines. And I'm so proud and to see these guidelines in practice. So in 2023, like I mentioned before, the threshold in Nigeria is a little higher, but I think that these are things we need to consider because we know the lower the blood pressure, the lower the risk of cardiovascular disease. In fact, in the American guidelines, we say ideally less than 120. But we still have a lot of people. Like I said, 1 in 3 people do not have their blood pressure control. So if we can get there, this is low-hanging fruit. We can get there. But in the Nigerian guidelines, I applaud the committee for identifying high risk, like I mentioned, people with diabetes, people with chronic kidney disease, people with heart disease. They set a target goal of less than 130 over 80. We use the Prevent Risk Calculator. They use the WHO CVD risk chart and identify appropriately people who are in high risk. they also have the same thing, initiation of therapy if blood pressure is greater than 140/90, with a lower threshold for those who are high risk. First line emphasis is calcium channel blocker centered in Nigeria. It's been shown to be efficacious in Blacks and within our setting. And that's why I really like these guidelines. You know, if you are starting an A to A or B, you have to be thinking about labs. Calcium channel blockers such as the amlodipine, nifedipine, they're really, I mean, you can get fewer labs. You may not even have to get labs for a couple of months. So in Nigeria, the emphasis is starting with calcium channel blocker. And implementing, I was so glad to see the concept of multidisciplinary team using community health workers, pharmacists, and tools to really get to that goal. This is the hypertension treatment control at the primary care level. You know, kudos to all our primary care internists on the call. My father is an internist. My mom, both of my parents are on the call. They're pharmacists. My mom's a pharmacist, retired pharmacist. My dad is a retired primary care internist. That is where high blood pressure control starts, at the primary care level. And they give explicit guidelines. If the blood pressure is high, start amlodipine. They wait till a month before they titrate. We're usually more aggressive, you know, in weeks, but we have more resources, telemedicine, home health. So this is reasonable in a low resource setting, and they give specific guidelines of how to titrate blood pressure medications to get to goal. And you can, if you drop your email, for those who logged on later, our ICOMAA US president mentioned that if you put your email in the chat after this call, the ICOMAA staff will be sharing with you the guidelines, both the hypertension guidelines for Nigeria and for the US. So if you put your information, we will send you further information after the call. Another thing that they do here is like, well, primary care, you can't get this blood pressure to control. Refer to specialist hypertension. And we also call that out. People who all they do is manage hypertension. They also talk about pregnant women. You know, if women are planning to become pregnant, do not use ARB, do not use ACE inhibitor. I'm so glad that they call out lifestyle changes, tobacco use, alcohol, and they talk about physical activity and weight. So kudos to all our professors, our senior colleagues who were involved in the writing of this guideline, because that's really put us on the map towards decreasing cardiovascular morbidity. And I said I will do my acknowledgements at the end in the interest of time. I want to acknowledge Emeritus Professor Oluwole Akonde. Thank you, sir, for being here and for all you do for the college. Acknowledging Professor Solomon Kadri, chairman of the hypertension guidelines, and one of my professors. I rotated in his unit. I acknowledge everyone here. Everyone here is important. Emeritus Professor Sam Omokodion, ICOMAA Worldwide President, pediatric cardiologist, and one of my professors. Professor Ada Asinobi, pediatric nephrologist extraordinaire. And this seminar today will not be possible. She is the chair of this webinar planning committee. I honor you, ma'am. And Dr. Modukwe Shokunbi, I mean, if you all can just use your virtual buttons to give her a warm round of applause. She has become like a big sister to me. She's our ICOMAA North America president. And Dr. Laia Gileye for your support, ICOMAA UK president. I recognize Professor Jesse Otegbayo, one of my professors in the GI unit, and also Chief Medical Director of the UCH, Professor Temitayo Ogunniyi, one of my professors, General Surgery 1, now Provost of the College of Medicine, Professor Olayinka Omigbodun, first female provost, my professor on psychiatry, Professor J.K. Ladipo, we go back a long way, general surgery professor and a family friend. And I honor ICOMAA Board of Trustee, Professor Funsho Famuyiwa, who happens to be my father's classmate. Fun fact about Professor Famuyiwa, he's been my mentor since I was a kid in New York and was actually the chairman at my wedding. I want to honor my family that's on the call, my parents, Sir Dr. Adekola Ashai and Lady Mrs. Josephine Ashai. My dad, classmates with Professor Famuyi were on the call. Thank you, sir, for your mentorship, and mom for your mentorship. My journey actually in hypertension started in my mom's pharmacy, B&B Pharmacy in Bodija, where she will teach us. As a middle schooler, I knew about diuretics, Modele. I knew about it, medications to treat high blood pressure because my maternal grandmother had high blood pressure. So thank you, sir and ma, for your mentorship and for your support. My heartbeats, my husband and my daughter, I honor you. Thank you for everything you've done. And I'm about to choke up. And my sister, class of 1998, quiet giant, Dr. Foluka, where ophthalmologist extraordinary in the United Kingdom. Some of the things I shared with you, my long-term collaborator and colleague and Professor Okechukwu Oga, thank you for sharing all those documents with you. Part of, as you heard when Dr. Shokunbi was reading my bio, mentorship is very dear to me, and I want to honor Dr. Bisi Oshikolu, who is my big sister from another mother, and Professor Buki Adeshino for the leadership of the Global Sponsor Student Program. The hypertension guidelines, I mentioned one of my classmates, Dr. Emmanuel Agogo, shared some documents with him, and he and I have collaborated in several ways, tackling the problem of hypertension in Nigeria and Africa. Professor Obioma Ochendu, thank you for putting together the polls, for helping me through all the IT issues, and the IT team of the College of Medicine. Thank you for all the time we spent together to get this together. And last but not the least, I honor my class 99 set, the best set to have ever traversed UI, famously known as the UCH 95 set. So thank you all. I acknowledge everyone. If I didn't call out your name, it wasn't because of lack of respect, but I honor you all, and I do not take for granted the opportunity to share this with you all. So I'll leave this up. You can scan this QR code. The first one goes to the website of the American Heart Association. The second one goes to the Journal of American College of Cardiology. It will take you directly there. And like I said, if you drop your email in the chat, we'll share all these resources with you. And I thank you for your time.
Thank you so very much, Professor Ogunniyi, for that insightful and practical presentation. It was quite engaging. You could see everybody there. It was really amazing. We learned so much, and also bridging the gap between the guidelines and clinical practice. We're now going to take a couple of questions from the chat. We do have one from, the first one tells you about, do the guidelines address race and ethnicity related nuances?
Yeah, thank you for that question. Yes, in the epidemiology, we know that Black people have the highest rates of hypertension. I don't know whether you're referring to treatment, but I will say another reason why we want a lower goal is that we know that Black people develop complications of hypertension at a younger age and at a lower threshold. So that's why we kind of lower the guidelines. The other thing we call out also is the impact of social determinants of health, the impact of stress, the impact of lack of insurance, lack of transportation, all those things that contribute to high blood pressure. So we talk about the role of the multidisciplinary team, community health workers, faith-based organizations that can tackle these things, all leading towards hypertension control.
Okay. Thank you so much. From Professor Gukule, he says, does the present classification of elevated high blood pressure not take into consideration the age of the adult? That, for instance, does it mean the same value in a 30 to 40-year-old male as opposed to 75 to 80-year-old male?
Thank you, Professor Ogunkule, for that question. we have looked at the evidence, the SPRINT trial, the CHRP trial, and irrespective of age, there's overwhelming evidence that controlled blood pressure should be 130/90. With the caveat that I mentioned, in people who have predisposition to orthostatic hypotension, like people with Parkinson's, people who are institutionalized, people who are on medications that will reduce their blood pressure, there has to be a caveat. So, but across the board, this guideline addresses adults. Anybody above 18, this is the goal pressure, because there's overwhelming evidence that treating blood pressure to goal reduces the incidence, the prevalence, and the mortality from cardiovascular disease and stroke.
Thank you so much. Dr. Lukman Adewale talks about integrating this guideline in Nigeria because their own blood pressure is greater than 140/90.
Yeah, I think that, that is, here, it used to be 140/90 many years ago. We can't even get people to 140/90. But we know that evidence, and not even in Black people, and when we talk about Black people here, we know that we're all an odd mixture, So I think that since the current evidence says that 140/90, let's walk towards that. And I'm hopeful that in the next reiteration of guidelines, we'll be able to get to at least 130. Because in these guidelines, we say less than 130/80, ideally less than 120. There is overwhelming evidence, including the SPRINT trial, that shows that the lower, the better, with all the other caveats that I raised. But kudos to the current guidelines. I think that we haven't even gotten there. If 100% of Nigerians with hypertension get to less than 140/90, then we can say, okay, let's lower the threshold. We haven't even gotten there. And even here in the US, 1 in 5 people do not even have their blood pressure, only 1 in 5 people have their blood pressure controlled, 25%. So it's a global problem. It's not a Nigerian problem.
And then Professor Rufus Akinyemi makes an important statement and a comment. Many thanks, Professor Modele Ogunniyi. The comment on the reduction of the risk of cognitive impairment and dementia control through high blood pressure is very vital. He comments that indigenous Africans have a relatively high proportion of VCI/VAD compared to the data from the global north. If you just want to say 1 or 2 sentences concerning that, please. You have to unmute yourself.
Sorry, I'm not familiar with the term VCI.
Professor Akinyemi, could you?
I know that reducing, like I said, one of the most things that stood out was that if you control blood pressure, you reduce the risk of mild cognitive decline and dementia by 15%. But I'm not familiar with what he means. I don't see the question.
Right. Thank you very much. I'm Rufus Akinyemi.
Yes.
By VCI, I do mean vascular cognitive impairment.
Okay.
Oh.
Right.
Okay.
Of VAD. Right. So from our review, we published quite work on dementia in Africans.
Yes.
We're undertaking a very large study at the moment.
Yes.
Across the 10 countries in Africa. What we've found from our reviews is that Africans have a very high burden of cerebral small vessel disease.
Mm-hmm.
And we think this is, of course, largely due to hypertension. So for us in Africa, in the global north, globally, Alzheimer's disease is the most common form of dementia. But we found that for Africans, we have a relatively high proportion of vascular dementia compared to the people in the global north.
Yes.
Due to hypertension, diabetes, and of course, emerging burden of cardiovascular disease, and possibly due to genetic factors as well. All these are currently being explored. So that's why I made a comment. And we found from our reviews that Black Africans do seem to have a very high burden of cerebral vascular disease, all due to the very high burden of cardiovascular disease, primarily hypertension. So your comment on reduction of blood pressure is an important intervention if we're going to reduce the future burden of dementia in Africans. That is why I'm.
Yeah, I totally agree with you, and congratulations and kudos to you for all the work you're doing. And that's why it's so important, to put out that data, I mean, and like you said, that is the number one thing that stood out to me, that controlling blood pressure reduces the risk of mild cognitive impairment and dementia. And like you mentioned, vascular dementia. So thank you so much, Dr. Akinyemi, for that comment.
And I think the last question, because of time, and we still have some time for closing remarks from our Father of the Day and the Chairman of the Day, will be from Emmanuel. And he writes, if the patient's average blood pressure is 140/90 or greater, but with no symptoms, should lifestyle modification be attempted first before commencement of medication?
The answer is no. So it's a blood pressure between 130 to 139, diastolic blood pressure 80 to 89, new diagnosis with no diabetes, no CKD, no CVD. That should be treated with lifestyle for 3 to 6 months. With a blood pressure of greater than 140, you're already in stage 1 hypertension. It should be treated.
Okay. Thank you so very much. Starting on existing protocols, I'd like to acknowledge that we have the Deputy Vice Chancellor Academic, Professor Juwon Arotiba here. Also the former Provost of the College of Medicine, Provost Olubunmi Olapade Olapa, and of course, one of our past presidents of the ICOMAA Worldwide, Dr. Habib Olamitoye. We thank you all for coming. In closing, I'd like to say thank you to everyone, and of course, especially Professor Folashade Akinshola, Dr. Femi Taiwo, Dr. Tunde Fakunle, Professor Major Shina Ogunniyi from the distinguished class of 1982, which I belong. I thank you for attending. And now for the closing remarks, we will ask, with all respect, sir, Professor Emeritus Wole Akonde, as the Father of the Day, to make some closing remarks, followed by the Chairman, Professor Solomon Kadiri. I thank you all so much, sir.
Thank you very much. The chairman of this webinar, Professor Solomon Kadiri. I wish to adopt the existing protocol, but kindly permit me to specially recognize the Provost College of Medicine and chief host of this webinar, Professor Temidayo Ogunniyi, the chief medical director, UCH, Professor Jesse Otegbayo, the president, ICOMAA Worldwide Emeritus, Professor Samuel Omokodion, the president, ICOMAA North America, Dr. Modupe Shokunbi, who is hosting and moderating today's webinar. Past provosts, past presidents of ICOMAA, presidents of other ICOMAA chapters, Professor Adanze Asinobi, chairman of the planning committee of this webinar, the Deputy Vice Chancellor, University of Ibadan, Professor Juwon Arotiba, distinguished alumni. I consider it a great honor and a distinct privilege to me to have been designated as the Father of the Day at this inaugural ICOMAA Worldwide Seminar. I congratulate the President, ICOMAA Worldwide Emeritus Professor Samuel Omokodion and his team for their vision in the conceptualization of this unique initiative. I also congratulate the presidents of all ICOMAA chapters for buying into the initiative. As we have been informed, the objective of this series of webinars is to provide an exciting platform for knowledge sharing, professional engagement, and global collaboration among Ibadan College of Medicine alumni worldwide. I enjoyed and learned a lot of new things from today's insightful and interactive lecture delivered by our most distinguished alumna, Professor Modele Ogunniyi. I congratulate Professor Ogunniyi for her erudite and excellent presentation. She has provided us with key updates and insights from the 2025 American Heart Association and American College of Cardiology Hypertension Guidelines. I'm indeed very impressed with the clarity of her presentation and the style too. Very interactive and very informative. Finally, let me take this opportunity to express my immense gratitude and deepest appreciation for the enormous contributions of our alumni given back to their alma mater, even under very difficult circumstances. I pray that you will all continue to receive God's abundant blessings. Once again, I thank the organizers of this webinar for the honor of designating me Father of the Day. Long live the Ibadan College of Medicine. Long live the University of Ibadan. Thank you all.
Thank you so very much, Professor Emeritus Wole Akande. Thank you for your leadership, your guidance. Thank you for accepting the honor of being Father of the Day. We are all so privileged. We thank you so much for your time. Now we're going to go to the chairman for some closing remarks, Professor Solomon Kadiri.
Good day, everyone. And I must join our father of the day, in thanking Dr. Ogunniyi for the excellent presentation we have listened to and watched this afternoon here, and this morning over there, perhaps. It's a very interesting topic, that of hypertension guidelines. And I think I can provide some information with regard to the efforts that have been made in Nigeria to combat this problem of hypertension. The Nigerian Hypertension Society, of which I am the foundation member, was started in 1993, principally by Professor Akinkunbi and some of his colleagues. And that society has produced three sets of guidelines. The first in 1996, the second in 2005, and the last in 2020. I was involved in production of the last two. But I must point out here that at no time was I president of the society, as was mentioned, when I was being introduced. I was just chairman of the guidelines committee. And I was a bit astonished that the guidelines shown by Dr. Ogunniyi were not the guidelines of the Nigerian Society of Hypertension, but rather the guidelines produced by the Federal Ministry of Health. A bit different, although some of our members were involved in that, the major guidelines and the body of work from the Nigerian Society of Hypertension and Hypertension Society is different from that. But nevertheless, the story of hypertension is an intriguing one. We started from 160/95, went down to 140/90, and now we've been told that 130/80 should actually be the cutoff points. And there's been some lag in the worldwide adoption of 130/80, because it would seem that the WHO is not totally satisfied with adopting 130/80 as yet. The last WHO guidelines stressed 140/90. But to my surprise, as with many things, America often has provided the lead. 140/90 started in America before other parts of the world kicked in and adopted 140/90. And it would seem that we are all moving towards what some people would call natural blood pressure, which is around 90/60. Because of course, they found that in most unacculturated societies, the blood pressure, when they first make contact with, it's about 90/60. I'm going to think that without the natural blood pressure, looks like we are heading in that direction. But there are implications. To get to 140/90, as Dr. Ogunniyi had mentioned, it's quite difficult. A bit difficult in America, a lot more difficult in Nigeria. Cost of medicines, knowledge, awareness, and things like that. But thankfully, too, I must say, there are lots of medicines these days, even in Nigeria, many generics, ARBs, ACE inhibitors, and even in glyphosate, quite a number. and they're available. We are moving in that sense. We're moving in the right direction, and we're making some progress. So we'll wait some time and see. There was a time when risk classification was kind of dropped by the Americans. They dumped it and went strictly by blood pressures. Blood pressure above 140/90 and above 160/100 were classified. And little consideration was taken into the presence or otherwise of risk of cardiovascular risk. But it looks like with these 2025 guidelines, a lot more attention has been paid to risk category in initiating treatment and indeed what form of treatment has been given. So it's good. As I speak, the Nigerian Hypertension Society is in the process of revising its 2020 guidelines, and a group was constituted sometime last year. They are looking into it, and hopefully they will produce the 2026 guidelines of the Nigerian Hypertension Society. I am aware, because one or two members have told me, that there is a dilemma. They already face a dilemma. What cutoff point should they adopt? 130/80 or 140/90? 140/90 is gaining traction. The ESC of last year, in 2024, advocated 130/80, and the American Heart Association 2025 clearly is rooting for that. So they're asking, do we use 160/90 or do we use 130/80? I guess in their deliberations, they would reach a compromise. So these are a few things from the point of view of the Nigerian Society and its efforts to produce guidelines over the years. The effort is continuing, and we've learned a lot today from Dr. Ogunniyi's presentation. We have access to the 2025 AHA guidelines. Many people have already acquainted themselves with the content that this will enrich our knowledge of modern practice in the management of hypertension. I'm quite impressed too at the attendance. Quite a large number of people joined today. And from the contribution of the questions that were asked, showed that many people had followed with keen interest. And a good number of our senior members also joined. Professor Famuyiwa, Professor Otolorin, they were all there. And it's quite good. So in ending, I would like to congratulate the ICOMAA Worldwide, ICOMAA North America, for this initiative. This is a very good initiative, and it has started very well, very successfully. So, and we've gained a lot, I'm sure, this evening. Professor Ogunniyi's presentation was excellent. We're very proud. I do not recall as a student in the group that she mentioned that she'd been in the renal unit. They're looking through the list of I saw quite a number of names, a few I'm quite familiar with. And what more can I say? That it's been a very good evening. And I'm sure we'll all leave this place with our knowledge enriched. And I'm sure we would all manage hypertension in a much better way, at least. We'll have that at the back of our minds. Thank you very much, ladies and gentlemen.
Thank you so much, Professor Solomon Kadri. On behalf of the Alumni Association, I want to thank Professor Modele Ogunniyi for this excellent presentation and sharing your expertise with us today. Of course, the father of the day, Emeritus Professor Wole Akonde, Professor Solomon Kadri, and all the dignitaries that we have mentioned before. Every single colleague that joined us today, I thank you all for your valuable contributions. We hope this particular session has enhanced your application of the AHA and the ACC hypertension guidelines in improving patient outcomes. I will not close without saying and respectfully acknowledging Professor Obioma Uchendu, a key member of the organizing committee whose exceptional leadership, dedication, tireless efforts, and commitment were instrumental into the success of this program. I'm deeply grateful for your outstanding contribution, in addition to Mr. Yetunde and his IT team for the expertise in facilitating the program. We'll now close with just a few words from Professor Adanze Asinobi and Professor Mokodion. I thank each and every one of you. Thank you. Professor Asinobi, please.
Thank you very much, our moderator, the North American president of ICOMAA. It's a great privilege for me to be the chair of the organizing committee that handled the organization of this webinar. I want to sincerely and deeply thank our guest lecturer for today, our own sister, an outstanding alumna of the College of Medicine, Professor Modele Ogunniyi. I want to thank our father of the day, who joined us from afar. We are appreciative of all you do for us, sir. I want to thank the chairman of this webinar of today, Professor Kadiri. I want to thank all the distinguished past presidents of ICOMAA, provosts and past provosts. You honored us, our deputy provosts. Everybody came, distinguished personalities, to attend this webinar. We are grateful. I believe that this is just the beginning. It has ended up very well, and I believe that it will continue to improve. And in the next 3 months, we'll be inviting you to join us in the next webinar that will be handled by the group from the United Kingdom. Thank you so, so much. I appreciate you all. I am a proud alumna of this college, and I'm very proud of our teachers, very proud of our elders, very proud of our products from all over the world. God bless you. I appreciate you all. Thank you.
Thank you so very much, Professor Adanze Asinobi. We're now going to close with Professor Samuel Mokodion. He's the president of this ICOMAA Worldwide, and this was his initiative. So without much further ado, Professor Mokodion, you're on, sir.
To say that I am so delighted at this takeoff is an understatement. I am very, very excited that we have gone off to a very good start at this inaugural edition of the ICOMAA webinar. And all the people that needs be thanked. Again, the list is far from complete. But I want to particularly, again, acknowledge Father of the Day. When I first called him and asked if he would accept the role of being Father of the Day, although he's on vacation, as may have been tangentially referred to, as always, is very, very, very enthusiastically accepted. Now, all the chapter presidents have bought into this idea. The North American president in particular, I don't think her passion in driving this, along with the chair of the organizing committee, is in doubt. And I know that the level of attendance with such people as the provosts, past presidents of ICOMAA, the chief medical director, and my classmates, Professor Solomon Kadiri, and all others who are on the platform today. it is evidence that we struck the right note in initiating these webinar series. And I am sure that you will all agree that we need to document, showcase, and let the name Ibadan College of Medicine be out there in the forefront as a very, very high-flying institution. I thank you all for attending and for staying on. God bless you. And I thank God that this has gone off to a very good start. Thank you in particular, Dr. Modupe Shokunbi, for very good moderation. And thank you, Professor Ogunniyi, for a very, very lucid presentation. God bless you. Thank you very much. Have a very delightful, good weekend of what's left of it. And thank you for giving part of it to this course. Dr. Obioma Uchendu, excellent work at the technical end. God bless you. And I will, on that note, call for the curtain to be drawn, and we look forward to meeting everybody and more at the next webinar. Thank you very much.